Alder Hey is a relatively large diabetes service. We've got 420 children together, about 400 type 1s, and we've got a relatively deprived social group. As you can see here, our patient numbers have risen steadily from 2013 up to this last audit year. We had a boost in our staffing in 2013 to help deliver best practice tariff, and that staffing has essentially stayed static ever since. We'd put in a business case in 2016 to increase staffing in line with our increasing numbers, and that struggled and stalled for a little while. Looking at our audit data, we received our 2016-17 NPDA report, and we were disappointed to see that after our initial improvement, we'd stalled, and we had a static median HbA1c from 2015-16 to 2016-17. We felt that this was reflective of the fact that we were now keeping children up to their 19th birthday with their known higher A1C anyway, and also the impact of these increasing numbers that you've just seen on our clinics, which hadn't expanded. We weren't able to deliver 4 MDT clinics a year. As part of that NPDA report, we received this, and we were disappointed to see that we weren't delivering 7 care processes adequately. We were marked as a negative outlier and received our outlier letter. We felt we'd already been working hard to try and improve this. We'd made improvements, and our 17% marker here was better than previous years, but clearly we were struggling. As part of the breakdown of those 7 care processes, there were some things we were doing well, and there were some things that we weren't doing well, and we were struggling particularly with thyroid testing, ACR testing, foot screening, and retinal screening, whereas other clinic processes were working well. Our approach to annual review, because clearly these processes were annual review processes, was that it was responsibility of the consultants. Annual review was performed at the clinic closest to the patient's birthday, and that meant putting them into a separate clinic code to bring them to annual review, and then remembering to book them back into a regular clinic afterwards. Blood testing, urine testing, feet checking, psychology screening was a challenge at annual review clinic. And to make matters worse, we'd lost our traditional fixed set of paper notes, and we'd gone paper light, which meant that flicking back through to see when the last annual review was didn't happen anymore, and finding that in our EPR was more of a struggle. Our approach to NPDA prior to 2017 was that we collected data, our audit department essentially managed it and then handed it back to us for a last-minute clean and tidy up before we submitted it. And in order to address that, in 2014 we bought into Twinkle to act as our data management for audit. And in 2015, we'd managed to get our EPR to link up with Twinkle and do some real-time transfer of results. We had minimum capacity to run reports, and our report was still a bit of a surprise when it arrived 12 months later. We felt it had little relevance to our current work, and we realised that it didn't reflect what we were doing. We'd made changes, but there was no real-time feedback. We hit a bit of a low point. We had a static median A1C. We couldn't improve our care processes because we didn't have extra resources. Our business case had stalled. And we'd applied for the college's QI programme, and we'd missed the first wave. We thought it was time to have some discussions. We held an away day, and about 12 months ago we met as a team, and we identified that there were things we needed to do. Everybody bought into this. We took responsibility for our data. Whilst we couldn't tell if our data was truly reflective of what we were doing, or whether it was that we couldn't collect that data adequately. It was our data. Let's take charge of it. We agreed to make some changes. We organised ourselves into groups and we discussed ideas. Everyone was committed to this. Our senior management had attended the away day and they said that they were going to support us with our plan. And we decided to concentrate on improving patient education and improving our clinic structure and processes. These groups held feedback sessions and met regularly and fed back to the wider team so that we all knew what was going on. Everyone was involved, everyone was engaged. And we started to see that we were doing things well. And one of our innovations was Star of the Month. Several Star of the Months are sitting in the audience today. We accepted that if we could focus on what we were doing, we could tell what was going well. There were a number of other innovations, and we decided to focus on patient education from diagnosis. We decided that if we improved the clarity and streamlined what we were doing, we could influence the direction of travel that these patients took. This is one example. This was a paper sheet with when to test, when to bolus, what to do, with visual reminders, because we've got a proportion of our population where English is not their family's first language. We also redesigned our newly diagnosed packs and the resources that went into that. Improving outcomes through patient education was a rolling programme, and this was driven by our NPDA data. As part of our focusing on education, we trimmed down our number of outpatient education sessions. There had previously been 4. Inpatient management to get you home was, again, streamlined, but the sessions that these families had to return for were reduced from 4 to 2. The location was moved so it was more accessible to the families, and we asked them to concentrate on weekly review of results. We were asking these families to download from diagnosis so that we could look at their trends and tailor their treatment. And clearly, this one's going to suggest certain changes straight away. We held a focus group. We asked our families and young people, what do they want? And in terms of information, they wanted more digital stuff. They asked us to redesign our website, which coincided with the Trust website redesign. They asked for information that was accessible. So we've created some videos that all of our families can access from anywhere. And we use some of these videos for our newly diagnosed families on the wards. And we got a Twitter account, which was a huge thing because our Trust was not keen to start with. In terms of improving outcomes, we were already using a sheet in clinic to record HbA1c, and this was updated and improved. It explains what A1c is for those that can't remember. Based on the fact that they were going to be downloading regularly at home, we said, why don't you look at your average blood glucose on your meter, and then there's a reference table so that you can see what your predicted A1c is going to be. And then there was a section for them writing notes so that they could remember what was said in clinic and it wasn't forgotten by the time they came out of the car at home. Uses positive language. There's a consistent message here. And we've asked them to call us if there's a problem. Don't save problems up for the next clinic. Many of our changes have been technology-based. Our median HbA1c is still most reliably collected on paper at the end of each month. And we use this data to track our median clinic HbA1c. And if you can't see the screens terribly well, this goes from August last year through to December that's just passed. And we've improved our median clinic HbA1c from 66 to 60.5 just gone. By using the NPDA website with its ability to frequently upload, we've been able to track these changes, and we're now uploading monthly. And what that's allowed us to do, by looking at that section at the bottom of the report, is to predict our mean unadjusted HbA1c, which, as you can see here, Alder Hey is the blue bars, national average is the red. We've gone from just above 70 to a predicted for this year of 64, and our median HbA1c has gone from 68 with a predicted for this year of 61.8, which in old money is 7.8%.
Thank you, Mark. So I'm going to take over now. You'll have to excuse me. I'm at the back end of a cold, so I've got a drink with me. I apologise if I do a Theresa May and start coughing. It's water. So the other area that we really focused on our away day is trying to improve care process delivery. So, of course, we were a national negative outlier for this and really wanted to focus on it to try and make some improvements. It was January in 2018 when we had our away day, and we realised that we still actually had 3 months to go to try and have a positive impact on our data. So Mark and Camilla, our data manager, came up with the idea of taking the Twinkle banner, which is colour-coded, and moving it to the top of the patient record. And we were now opening Twinkle and inputting data actually in the clinic environment. So for every patient, as soon as you open their record, you immediately could see which care processes were missing. And because we had this whole team approach, the nurse or the dietitian, whoever was at the computer, would be, oh, okay, we need to get these things done today in clinic. So that really helped us in that final 3 months. The second thing that's made a really big difference to us is Camilla, our data champion. So she, manages our database brilliantly and puts a huge amount of time and effort into making sure that our data quality is now really good. One of our big challenges was our urine ACR results. We had a problem where our results database within the hospital wasn't communicating accurately with our diabetes database. So in actual fact, for 2017-18, Camilla manually uploaded well over 100 urine ACR results to the NPDA. She's also spent a lot of time liaising with our hospital IT department, with the database IT department, emails, telephone conversations, meetings to try and sort out this interface problem, and we are relatively optimistic that this might now be sorted. Our final and probably biggest change is a move to block delivery of care. So we had the idea that we would move to delivering all of our annual reviews between April and July. So any child or young person that came to diabetes clinic between April and July would have their annual review completed. The idea being that we then still had another 8 months to catch up with anybody that we'd missed using the banner within the patient record. We had some worries about this, how patients and families would find it. So we wrote to them all and then also continued to explain it in clinic. And actually, when we explained why we were doing it, they were generally all very happy with the change. We were also concerned about the impact that it would have on our clinic staff. But in actual fact, within a couple of clinics, they were very happy with the change because finally they knew what they were doing. Everybody needed their bloods doing, all the over 12s needed a urine sample pot. So in actual fact, it made life easier for them as well. Although we've not shown you the data, we have had problems with ensuring that all of our young people have their psychology screening. So it then gave us the opportunity to focus on psychology screening for a block as well. And once again, we've had significant improvements in that. And finally, we now have an education block. So at the moment, one of our aims is to reduce the number of DKA admissions that we have. So we're using the education block as an opportunity to run through illness management, hypoglycemia and high ketones management with all of our families. I think the thing to mention is that because we were all focused on annual review and all focused on delivering the care processes, that's why having this system has really worked for us. So once again, how do we know that a change is an improvement? So just like all the education changes that we made, we monitored median HbA1c. Well, for us, the online NPDA platform has been an absolute revelation. It's made a huge difference to us because we now upload once a month to see how we're doing with our data. And essentially from August, we set the target that from August, we should be at 100% for care process delivery. We're not there, but you know, in our minds, that's what we're now aspiring to. And so we upload the data monthly, and we then proactively manage any gaps in our data. This is a very low-tech solution, but we have sticky paper that's up on the wall in the office. And so it's there for everybody to see, and it's very satisfying getting the purple pen and adding another little block of where we're up to with annual review. And it's now not unusual to find a couple of us stood with a coffee looking at the board saying, why have 12 young people escaped our clinic without a foot examination? So, what has it done to our data? Well, we can see that for albuminuria screening, which we probably struggled with the most, we've gone from around the mid-30s to 55%, and we're now confidently at 80% for albuminuria screening. Thyroid check has gone from about 71%, we're now up to 89%. This is all for the over 12s. Foot screening, we've gone from about 56%, up to 91% just using the banner, and then 94%. And of course, this is our predicted data for 2018-19. But again, we're confident that this is going to improve further because we've still got another 3 months of the year to go. Eye screening, I'm just going to mention separately because this is out of our control. It's delivered by 3 screening centres in Liverpool, a service that's commissioned by the CCG. So obviously we don't have the influence to get them to deliver annual review in blocks. But we actually managed to get quite a big improvement with our 2017-18 data, with Camilla building up working relationships with the screening coordinators in those centres. And so now she will regularly email them and get them to send their data to us. And we're no longer relying just on the families bringing the reports into clinic. So for 2018-19, we're approaching 60%, but of course, remember, we still have a quarter of our children to complete their eye screening. So again, we're optimistic that will improve. So our 7 care process data. So just in that last 3 months after our away day, we managed to get ourselves up to 43%, which we were very pleased with. For 2018-19, we're now up at 46%. I think primarily our issue there is related to the eye screening. So again, we still have 25% of our kids to have their eye screening. So we know it's going to improve. I guess we just don't know how much it's going to improve by. So fingers crossed we won't get another national negative outlier letter. For this at least. And so what about our business case? Well, this was a really hard slog. It's fair to say that the outlier letter was actually very helpful. It did raise our profile in the trust. And at the time, as far as we were concerned, it was for all the wrong reasons, because we felt like we were working really hard to deliver good quality care to our patients. But in actual fact, we didn't have the staffing to deliver enough clinics. And once we took ownership of our data, we actually incorporated it into the business case, and we were able to make a really strong quality argument within the case. We presented our data in detail to our executive team, and I'm pleased to report that towards the end of summer last year, the business case was approved, and now we're currently in the process of recruiting to a full complement of staff for the full MDT. So, nearly there. So we've thought a lot about what has made the difference for us really over the last 18 months. I think the first thing undoubtedly is taking ownership of our data, taking responsibility for the fact that it was quite frankly rubbish, and that it was within our gift to improve it. The second thing was a whole team approach. The improvements that we've made, I'm certain that we couldn't have made them without everybody, the whole team being invested in making those improvements. From the changing the education packages, to giving that clear and consistent message in clinic that has improved our median HbA1c, to everybody being on it in clinic to try and deliver those care processes. We've all become somewhat obsessed with turning the red to green on the banner. Getting the systems right is incredibly important. I think we've all realised that with our systems, we need to change them to make them as easy as possible for everybody to do the right thing. We actually all want to do the right thing. It's just sometimes our systems are designed to make it challenging. And I think that's one of the things that we've recognised with our annual review process. So that's not going to work for everybody, but for us, that was the right solution. And now that system's right, I think we're just going to continue to improve. Finally, embedding quality improvement into the structure of our service. So we now have a monthly quality improvement meeting. We've become a much more proactive and agile service. We are always looking at the next thing that we need to do, next thing that we need to work on to improve the care that we're delivering. And I'm delighted to say we are now part of wave 2 of the RCPCH QI programme. And that's been really helpful, just getting that QI training and ethos for the whole team, and we're now looking, as part of that, we're working on admissions specifically. But it's also been really useful to meet with other teams, share experiences, and from our meeting on Wednesday, we were in Leeds on Wednesday as well, and we've already taken back lots of good ideas that we're now thinking about how are we going to implement this. And we've moved away from, okay, somebody's got an idea, it goes to team meeting, and then a few months down the line, maybe finally we're on version 12, we might get it approved. We're like, okay, next week, somebody get this done, let's do it next week. So we've stopped making perfection the enemy of improvements, I think it's fair to say. And then, I'm going to cringe a bit now, but final message is the team that dresses up together improves their services together. Thank you very much.